Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers, producer of Public Health on Call. Today, seeing violence as an infectious disease. Dr. Gary Slutkin is a physician and epidemiologist and the founder of Cure Violence, a community violence intervention program that started in Chicago and has been implemented in cities around the world. He joins Dr. Josh Sharfstein to talk about his new book, The End of Violence: Eliminating the World's Most Dangerous Epidemic. They start with some personal history, where Dr. Slutkin introduced the idea of treating violence as an infectious disease to Baltimore about 20 years ago when Dr. Sharfstein was serving as health commissioner of the city. Let's listen. Dr. Gary Slutkin, thank you so much for joining me today on Public Health on Call. How are you doing today?
I'm doing wonderful today. How are you doing?
I'm doing okay. I'm doing better now that I get to see you. I'm trying to think how long it's been since we first met. That must have been sometime about 20 years ago.
Yeah, that's about right. I think that we began to interact with Baltimore around 2005 or 6.
And we, at that time, what was the name of the...
Well, it was Ceasefire then.
Ceasefire Chicago initially. And then was Baltimore your first replication site?
It was the first site outside of Chicago. And so we were very keen to see if it could work somewhere else.
And Baltimore, as many of our listeners know, has had a long time challenge with violence and homicide. And right before I became health commissioner, the city had reached out to you to see whether the kind of work you were doing in Chicago might work in Baltimore. And it was described to me when I started as bringing an infectious disease approach to addressing violence. And I just remember being puzzled and calling you and asking you to explain what that was about.
Yeah, it was Catherine Fine who visited us on behalf of the health department at the time. And I think it was an unusual idea at the time. Maybe still is for a lot of people. But yeah, that's the way I saw this. And it's the way that we began to manage it. There's a contagious disorder or disease.
Yeah, and I remember meeting you, and you started out by talking about, I believe, the spread of tuberculosis. Is that possible?
I start too many conversations that way because that's where I learned how to manage an epidemic in San Francisco. I was working at the tuberculosis program, and then I got elevated to having responsibility for it. And I got mentored, and that's how I learned how to manage an epidemic.
Now, we'll get to your book and all the things you have done since 20 years ago. But back then, some of the core elements were there, right? I mean, you talked about the importance of interrupting transmission. And to me, that was a revelation, again, that we should think about the transmission of violence, the cycles of retaliation, and the opportunities to intervene.
Yeah, I didn't invent the playbook for how to manage an epidemic. I had learned it, and it turns out it gets applied pretty much to almost all epidemics. And it's about finding the most active, what we call cases. In this case, people who are most likely to do a shooting. For tuberculosis, those who are coughing the most. And managing them, cooling that process down, and preventing spread to other people. And then there's so many other aspects to it, as you know, the community responding and public education. But that's the center of it. And all we did is just try it out.
Right. Well, that was a lot. And it was a definite change for the health department to be doing something like that. I remember you're advising us, but you'll tell me if I'm remembering wrong here, that we're not hiring people 9 to 5. And we're looking for a particular kind of person to hire to participate in a program like that.
Yeah, it's always, especially for violence, because so much activity of violence occurs in the afternoon, late afternoon, evening, and all through the night. So yeah, it's kind of like a fire department has to be on call all the time, awake and alive and active whenever there is a need.
And, inherent in that is the concept of violence interruption. And so the call comes at 11 at night. Tell me how you expect a public health worker who's addressing violence instead of tuberculosis to respond.
Well, the essence of this is being able to have an awareness. The worker needs to have an awareness of who is thinking about or considering or likely to do a shooting tonight or now or soon. And that we have hired the people who have access to that person in advance. So we have people who have access to this group and to that group and to that group and know them already. And their job is to be alerted or to be looking for that. And they need to get on the phones and in their vehicles or down the street and say, how you doing? How's it going? And then take all the insults and screaming and complaints and listen to them and validate their concerns and buy some time and the need for cooling down the situation, buying some time, and then shifting their perspective and allowing that they can save face with their friends and stay physically safe and socially safe. And there's, of course, as you know very, very well, it's a lot of work in selecting the right people, training them, supporting them. And Baltimore is a brilliant experience with finding the right people and training them and seeing the results of it.
I certainly remember some incredibly inspirational leaders of what we called Safe Streets in Baltimore. That was the Ceasefire Chicago site here. And the work that they did, I remember being health commissioner, visiting them, talking about the kind of work. And I also remember some of the early data that came in. Professor Daniel Webster here at the School of Public Health found not only reduction in shootings, but also changes in the attitudes about violence in the areas where these teams were working.
Daniel's work really revealed some things that we didn't expect to find. I mean, we were hoping to find reductions in shootings and killings and did. In some neighborhoods, they went long streets without any shootings or killings. And I remember Cherry Hill was going 350 days or 450 days, I think, at one point. They subsequently repeated that. Daniel Webster found the norms had changed. The expectation of what they thought the expectation of them was and what they said they would do under various circumstances. But what was especially cool about that was that those attitudes or expected behaviors or norms that we say had also shifted in the next neighborhood over, which is beautiful. This is what you find in public health, is that, if the moms learn about breastfeeding, then the next neighborhood, the moms learn it. So it had spread. The other really important thing was the relationship between the number of interruptions and the number of killings. And that was like, how many people with TB you keep on therapy and the result. Numbers of people immunized with measles and the reduction of measles cases. So that this became an intermediate indicator with power.
Now, if we fast forward 20 years, you just published this book, The End of Violence, Why Is It a Disease and How It Can Be Cured. And back then, Baltimore, I felt like all of your attention was on Baltimore. You came many times to the city. At one point, you and I worked with the Mayor Sheila Dixon, to raise money for a whole bunch of replication sites. And those were, I think, a contributing factor to a significant decline in homicides in the city around that time. But then you've done many other things. So take me past Baltimore.
Since Chicago and then Baltimore, there are 60 cities that Cure Violence has worked in 20 countries. So this became, and there are about 20 or 25 studies, about 12 or so that are independently funded. So there's just so much data now. And even in Latin America, and there's about a dozen cities now in the country that have gone to record lows or 50 or 60-year lows. And the relationship to this approach cannot be really denied. There's about 90 cities that have gotten money from the prior administration to do some parts of this, whether it's active case finding, community responses, public education, and violence interrupters are now like all over the country. So it became a movement, and it's sometimes called community violence intervention, but there's dozens of names and hundreds of organizations, and I mean, probably thousands of community organizations now that are doing some aspect of this or the whole thing.
Now, one thing I found really interesting in your book that I don't recall us talking about 20 years ago is how understanding the brain helps to understand why these kinds of public health approaches can be effective.
Yeah, I'm really glad you brought that up. So the book, The End of Violence, describes why we feel that violence can really go to zero or near zero. In fact, there's about 25 communities that have gone to zero for a year to 3 years. But what the End of Violence book says is why this is behaving like a disease, not just that it is, and why it is contagious, not just that it is, and that all of these different types of violence, from mass shootings to war to community violence to violence in the families, how they're all part of the same disease, including, in fact, authoritarian violence disorder. And they're all operating also by the same brain processes that you asked about. And this is a large part of the first half or first third of the book. And basically, just as briefly as I can say it, there are very specific mechanisms in the brain that don't care about good or bad or right or wrong or dangerous or safe. And those include copying. Copying just is what the brain does. The feeling of pain, which there's pain centers, and the feeling of needing to get out of the pain, which are largely dopamine mediated. And those things can go into really overdrive. So there's so much detail here, not enough time in this session, but chapters on this, on exposure, on susceptibility, on how the brain on violence, as well as chapter on interruption and norms and on violence of the state.
So this started with your observation that an infectious disease approach could be successful, with you replicating that model and then going deeper into the question of why.
Yeah. I mean, I could see 25 years ago or so that violence had all the characteristics and criteria of a disease. But what I didn't know so well was how this works. I mean, we know how COVID works. We know how cholera works. We didn't know how this was working. And so that I had to spend a lot of time on, and I learned a lot in the writing of this book that I didn't know about the details of I mean, it's kind of like with germs, people didn't know about them for a long time, and people have not known about these processes for a long time. And so this is so important because in order to prevent a problem from spreading, you have to understand it. We know this in medicine, not everybody, fully connects with that.
And it also gives the opportunity to strengthen interventions, to start somewhere and to learn what's working and what's not working and say, let's replicate it, but let's try to do it a little bit differently and see if it works. Let me ask you a question. There may be some listeners who think, community violence intervention is great, but this is really all about law enforcement. That's what homicides is about. And I know that your programs that you've been involved in, have had different relationships with law enforcement. How do you think about the public health strategies intersecting with law enforcement to produce the best outcomes?
I mean, law enforcement has a role in many epidemics. I mean, for some help in preventing spread, occasionally the need for isolation or quarantine and being helpful with it, but they're never the front line. I mean, no matter what epidemic you're looking for, they're never the front line. So I have usually always somewhere in there seen law enforcement as the backup to the backup.
And so let's treat it like a public health challenge. First, work with law enforcement, as you said, a partner that's there when you...
The essence of the misunderstanding of this is seeing people who have had a lot of exposure and grown up with it being normal in their neighborhoods as fundamentally bad, morally bad, rather than having acquired a problem. And so therefore, in that construct, people believe that punishment is the way to deal with people who are considered bad. But this is what we thought of people with leprosy or cholera or plague. So we would throw widows in the well, or put people in dungeons before we understood the problem. It's not as if law enforcement is irrelevant. It's just that people can't cool people down. If they're the right people, at the right time, in the right place, and properly supported.
And then you're able to prevent violence in the first place.
And look at what Baltimore's been able to accomplish. It's at, I don't know, is it 60-year lows?
Right.
If it's not historic lows, one of the most affected cities with some of the most affected communities in the country is doing great. And we're thrilled. And I would say also to our Baltimore brothers and sisters and friends and colleagues, congratulations.
Well, we've had the mayor on this podcast talking about it and talking about the public health approach the city has taken. And of course, there are a whole bunch of strategies that are underneath that, but Safe Streets is still here and is one of those core strategies. It is amazing how far the city's come. It's amazing to see you after 20 years, to read your great book. Gary Slutkin, it is so great to see you again. Thank you so much for joining me today.
Thank you, Josh. Great to be with you again as well.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.